Welcome back to the deep dive. Today, we're really zeroing in on one specific condition. We're using revision content, all aimed at getting you ready for the MSRA exam. The focus, Lentigo Maligna.
Exactly.
We've got the material right here, and the mission is simple. Extract the absolute must-know, high-yield facts, the stuff that's likely to pop up. We want to do it quickly, clearly.
Yep, think of it as a targeted briefing.
This deep dive should give you a solid, efficient overview of Lentigo Maligna without getting lost in the weeds.
That's the plan. We're filtering out the noise, highlighting what's really critical for your revision. We'll cover, the definition, causes, like diagnosis, treatment, the whole picture.
Perfect.
Yeah.
Let's get into the core facts then, starting right at the beginning. What exactly is Lentigo Maligna?
Okay, so fundamentally, Lentigo Maligna is a type of melanoma. But, and this is key, our sources define it as melanoma in situ.
In situ. So, meaning it hasn't spread, it's stayed put.
Precisely. It's confined entirely within the epidermis, that very top layer of the skin. It comes from atypical melanocytes, the pigment cells, but those abnormal cells haven't breached the basement membrane to go any deeper.
Right, okay. Melanoma, but just in that top layer for now. What does it look like?
Typically, it shows up as a flat brown patch or lesion. And interestingly, this is a useful point. The material highlights, unlike, say, a regular freckle or even a solar lentigo, which might darken up after you've been in the sun recently. Lentigo maligna doesn't usually change color much with that kind of short-term sun exposure.
Ah, okay. That is a helpful distinction.
Yeah.
So flat brown doesn't really react to recent sun. And where does it usually show up?
Overwhelmingly, it's on sun-exposed skin. Think face and neck, those are the classic spots. The sources describe its growth as slow.
Slow growth.
Yeah, but that's a bit deceptive because, and this is the crucial bit, if you leave it alone, it absolutely has the potential to progress. It can turn into invasive melanoma.
And that's the real danger zone, isn't it, when it crosses into those deeper skin layers?
Exactly right. Size and shape can vary quite a bit. Often it looks irregular, which, makes diagnosis a bit tricky sometimes.
I see.
Our sources also place it in context, mentioning other related pigmented spots like simple lentigo or solar lentigo, common sunspots, just to differentiate LM as the one with that malignant potential.
Right. And sometimes these lentigenes, these spots, they're part of bigger pictures, syndromes. I think the material mentioned Peutz-Jeghers.
That's right. Peutz-Jeghers syndrome is a good example, with its spots around the mouth and such. Or leopard syndrome. It's just a reminder that sometimes a skin finding can be a clue to something systemic.
Okay, good context. So we know what it is, what it looks like, but why does it happen? What's the cause, and who's most at risk? Let's talk etiology and risk factors.
Well, the exact mechanism isn't perfectly understood, but the sources are really clear on this. The single biggest driver is chronic sun exposure. We're talking about the cumulative damage from UV radiation over many, many years.
So it's not just about one bad sunburn last year.
Not usually, no. It's more about that lifetime dose of UV. Think of it like wear and tear on the melanocytes' DNA from decades of sun.
Makes sense.
Other contributing factors mentioned are things like, well, genetic predisposition plays a role, getting older is a big one, having fair skin, and maybe a history of significant sunburns or skin damage in the past. These all feed into the main risk factors.
And what are those absolute key risk factors we need to have locked down for the exam?
Okay. Top of the list, advanced age, especially people over 60. Fair skin is another huge one, skin that burns easily.
Right.
And as we said, that extensive chronic sun exposure history, that's probably the defining risk factor. The material also points to things like a weakened immune system and, importantly, a personal history of previous melanoma or other skin cancers. That definitely bumps up the risk.
It's really interesting how that link between the chronic sun exposure and risk keeps coming up. It really drives home that it's the slow, steady damage over time that seems to be the main issue here.
Absolutely.
All right, let's go a bit deeper now. What's actually happening at the cellular level? Talk us through the pathophysiology.
Okay, so it starts with those melanocytes we mentioned, the pigment cells living in the basal layer of the epidermis, the bottom of that top skin layer. Years and years of chronic sun exposure, the UV radiation, it causes damage to their DNA. Leads to genetic mutations, changes.
Sort of scrambling their instructions.
Kind of, yeah. It disrupts the normal controls on growth. So these now atypical melanocytes start to grow and multiply in an uncontrolled way. What's characteristic of Lentigo maligna itself is this slow radial growth pattern.
Radial, meaning it spreads outwards
Right.
horizontally.
Exactly. Spreading sideways within the epidermis, like
Yeah.
roots just under the surface. But the critical point, the so what, is that while it's doing that horizontal spread,
Yeah.
it keeps the potential to eventually start growing vertically, downwards, breaking through that basement membrane and invading the dermis, the layer below. And when that happens, it's no longer just Lentigo Maligna, it's now Lentigo Maligna melanoma. That's invasive melanoma, and it carries a much higher risk of spreading, metastasizing.
Okay, I see. So it's flat, it's pigmented.
Mm.
But lots of things on the skin are flat and pigmented. How do doctors tell Lentigo maligna apart from all the mimics? What are the key differential diagnoses we need to know?
Yeah, this is a really important point for practice and definitely for exams because telling LM apart from other brown spots can be genuinely difficult. The list of things that could be is pretty long.
Okay, give us the main contenders from the sources.
Well, first you got to think about benign lentigens, especially solar lentigens, those common age spots or sunspots. Seborrheic keratosis is another big one. They often look a bit greasy or stuck
Oh,
on.
I know the ones.
Then, of course, you have to consider other types of melanoma, especially an early superficial spreading melanoma might look similar at first glance.
Okay, what else is on that list?
Let's see, actinic keratosis is mentioned. That's a precancerous lesion, also sun-related. Ephelides, which are just freckles, can look similar, but they tend to be smaller. And crucially, they do darken with recent sun, unlike LM usually does.
Mm-hmm.
The material also lists seborrheic warts, just another name for seborrheic keratosis, and even rare conditions like xeroderma pigmentosum, which involves extreme sun sensitivity.
Wow, okay. That is a lot of flat brown things. So how do you actually make the call then, if it's so tricky?
Well, your clinical judgment, looking closely, that's the start. But you really need backup. Dermoscopy using that special handheld scope with magnification and polarized light is super helpful. It lets you see patterns under the surface you just can't see with the naked eye.
Okay.
But ultimately, the gold standard, the only way to be absolutely sure, is a skin biopsy. You need to get a sample and have a pathologist look at it under the microscope.
Right, biopsy is key for confirmation. Thinking about all those lookalikes, is there any sort of quick way to remember the main flat brown spots? A mnemonic, maybe?
You could try something simple just to run through the big ones in your head. Maybe.
Yeah.
F, S-A-L-M, F for freckle, S for seborrheic keratosis, A for actinic keratosis, L for lentigo maligna itself, and M for melanoma, other types.
FSLM, FSALM, freckle, seb-K, actinic K, lentigo maligna, melanoma. Yeah, that covers some key bases. It's a good quick chat.
Exactly. Not exhaustive, but hits the main ones.
Okay, useful. Now, let's think bigger picture again. Where do we tend to see this condition most? Who gets it? What's the epidemiology look like? Especially thinking about the UK, which our material mentions.
So the sources say precise UK data isn't always perfect, but it's definitely recognized as a common subtype of melanoma over there. Given that strong link to chronic sun damage, you'd expect it, and you do see it more in populations with higher lifetime sun exposure.
Right, that follows from the cause.
Absolutely. But the most striking thing in the epidemiology, the thing that really stands out, is age. Lentigo maligna is predominantly a condition of older people. Specifically, we're talking age 60 and over, often much older. It really takes decades of sun exposure to develop, typically.
And are numbers going up? Are we seeing more of it?
There's a suggestion in the material that the reported incidence might be on the rise.
Yeah.
Now, that could be a genuine increase, maybe due to lifestyle factors or people living longer. But it's also very likely influenced by, better public awareness, doctors being more alert to it, and improved diagnostic tools, just picking up more cases that might have been missed before.
Okay, that makes sense. So we've got what it is, the why, the who. Let's bring it right back to the clinic. What does it actually look like when you see it on a patient? What are those key clinical features we need to spot?
So the classic picture, as we've touched on, is that irregularly pigmented lesion. Location is vital, almost always on chronically sun-exposed skin, face, and neck are prime locations.
And you said flat, right? What about the color and edges?
Typically flat, yes. The color is often the giveaway. It's usually not one uniform shade. You might see variegation, different shades from light tan to dark brown, even black sometimes, all within the same patch. And the borders are usually irregular, kind of fuzzy or ill-defined.
So flat, patchy color, irregular edges.
Yeah.
Anything else? What might the patient notice?
Well, the history is often one of very slow growth over months, usually years, even decades sometimes. The shape might slowly change or the colors might shift. Most of the time, it's asymptomatic, doesn't hurt, doesn't itch.
Mostly asymptomatic.
Mostly. But occasionally, patients might report some mild itching. Bleeding is less common for LM in situ, and if it occurs, it definitely raises concern about possible progression to invasive disease. Size-wise, by the time they're often diagnosed, they're frequently larger than 6 millimeters in diameter.
Larger than 6 millimeter. That rings a bell.
Yeah.
Part of the ABCDE rule.
Absolutely. The ABCDE checklist for pigmented lesions is crucial here. A for asymmetry, B for irregular border, C for variable color, D for diameter greater than 6 millimeters, and E for evolution or change over time. Lentigo Maligna often ticks several of those boxes, especially B, C, D, and E.
Right.
And remembering that it's this slow-growing precancerous thing with roughly a 5% chance, the sources suggest, of eventually turning into invasive melanoma, that's what makes spotting these features so important.
Okay, let's try a quick scenario. Imagine, say, an 80-year-old patient comes in, points to a flat, brownish patch on their cheek, says it's been there for ages, years maybe, but they think it's gotten a bit bigger recently, and the color seems, well, patchy, not even like it used to be. It's about a centimeter across. What's going through your mind?
Okay, yeah, that's a textbook presentation that should immediately ring alarm bells for Lentigo Maligna. You've got the age, the sun-exposed site, the long history, but with recent change, that evolution is key. The flatness, the size over 6 millimeter, the irregular color, it hits all the classic markers. That patient absolutely needs further investigation.
Right. So speaking of investigation, we see that suspicious lesion. What are the next steps? How do we confirm if it is Lentigo maligna?
Well, it starts with that good clinical look, using the ABCDEs, examining the whole lesion, the surrounding skin, feeling the nearby lymph nodes just in case there's any hint of something deeper.
And then using tools.
Exactly. Dermoscopy is pretty much essential as the next step. That scope lets you see those subsurface patterns we talked about, which can strongly point towards or away from LM. But, like we said, the definitive, rock-solid diagnosis, that comes from the skin biopsy.
What kind of biopsy exactly?
The sources mention either a full-thickness punch biopsy, taking a small core of skin, or sometimes an excisional biopsy, where you try to remove the whole thing initially if it's small enough and suspicion is high. The key is getting enough tissue for the pathologist to see those atypical melanocytes clearly within the epidermis.
Okay. And what about things like scans? Do they play a role?
Generally, no, not for straightforward lentigo maligna in situ. Imaging like ultrasound or procedures like sentinel lymph node biopsy, they only really come into the picture if there's a strong reason to suspect it's already progressed to invasive melanoma and you're worried about spread.
Gotcha. The material also mentions some newer things helping with diagnosis.
Yeah, techniques like reflectance, confocal microscopy, which is like an optical biopsy almost, and special immunohistochemical stains used in the lab are improving diagnostic accuracy, especially for difficult or borderline cases.
All right. So we've spotted the lesion, done the biopsy, confirmed Lentigo maligna. Now what? How do we treat it? What's the typical management approach? Thinking about UK guidance.
The number one goal is complete removal. And for that, surgical excision is really the gold standard. It's the first-line treatment, the most reliable way to get rid of it completely.
Are there specific surgical methods?
Yes, the sources talk about standard surgical excision, where you cut it out with a margin of normal-looking skin around it. They also mention Mohs micrographic surgery.
How does that work?
With Mohs, the surgeon removes the visible lesion and then removes very thin layers of skin around and underneath it, checking each layer immediately under a microscope. They keep going layer by layer only where cancer cells are still seen. It aims to remove all the roots while sparing as much healthy tissue as possible. It often gives very high cure rates and can be good for cosmetically sensitive areas like the face.
Okay, so surgery is the main approach. What if someone isn't suitable for surgery? Maybe they're too frail, or the lesion is in a really awkward spot.
Good question. The material does list non-surgical options for those situations. Things like cryotherapy, freezing it, although the sources caution it might be less precise in ensuring complete removal. There's also topical imicumod cream, an immunotherapy cream applied over several weeks, and radiation therapy is another possibility, sometimes used with careful mapping, especially for large lesions on the face in older patients.
And the sources mention different roles for primary and secondary care?
Yeah, that's relevant. For clearly benign spots in primary care, maybe very light freezing for cosmetic reasons, or sometimes doctors might try unlicensed topical creams like tretinoin to lighten them. But, and this is vital, any lesion that looks suspicious or a confirmed lentigo maligna needs referral to secondary care, to dermatology. That's where the definitive biopsy and specialist treatments like proper surgical excision, the main treatment for LM, or those other non-surgical options are managed. Lasers like Q-switched or IPL are generally reserved for benign solar lentigens, not LM, and even then carry risks like pigmentation changes.
Okay. And once it's treated, is that it? Job done.
Not quite. Follow-up is really important after treatment for Lentigo Maligna. Close surveillance is needed to check the site for any signs of it coming back recurrence, and also just to keep an eye on the patient's skin generally, as they're at higher risk for other skin cancers too.
Right. Makes sense. So what's the bottom line for someone diagnosed? What's prognosis like?
Generally, it's good news. If it's caught and treated properly while it's still in situ, the prognosis for Lentigo Maligna is excellent. The overall survival rate is very high because the risk of it spreading when it's confined to that top layer is extremely low.
So early detection, proper treatment, great outcome.
That's the key message. Early and complete treatment makes a massive difference. But, and this is the crucial flip side, if it's left untreated or if the removal isn't complete, it can progress to invasive melanoma.
And if that happens, the outlook changes significantly.
Very significantly, yes. Invasive melanoma has that potential to metastasize, to spread to lymph nodes or elsewhere, and that obviously carries a much more serious prognosis than the in situ stage. Preventing that progression is really the name of the game.
That weed analogy you mentioned earlier seems quite fitting. Catch it when it's just on the surface, get it all out, lawn saved. Let it root down deep. Much bigger problem.
Exactly. Removing it completely while it's still just horizontal makes all the difference.
Are there other problems? Any potential complications we should be aware of, either from the LM itself or the treatment?
Well, the main complication of Lentigo maligna is that progression to invasive melanoma we've stressed. That's the big one to avoid.
And the consequences of that progression.
It means more extensive treatment, needed wider surgery, maybe lymph node procedures, potentially systemic treatments like immunotherapy or targeted drugs if it has spread. These are all much bigger undertakings with more side effects than just dealing with the in situ lesion. And then, of course, the treatments themselves can have complications. Surgery always has risks like infection, bleeding, scarring, which can be a concern on the face. Incomplete removal leading to recurrence is another issue. And the non-surgical options like imicomod or radiation, they have their own potential side effects too, which the material outlines.
Okay. Wow, that was a really thorough run-through of Lentigo maligna. Super clear. We've covered the definition melanoma in situ, the massive role of chronic sun damage, what it looks like, why it's tricky to spot sometimes against other lesions, who's most at risk, what's happening cellularly, the diagnostic steps, the treatment options focusing on excision, and that really critical difference in prognosis between in situ and invasive disease.
Absolutely. Understanding those key features, recognizing it clinically, knowing the potential for progression, it's all vital stuff for MSRA revision for anyone seeing patients with skin lesions. Spotting it early is the first most important step. And maybe just a final thought for listeners. Given that it grows so slowly and usually appears on sun-damaged skin in older people, just think about the power of regular skin checks. What role can proactive surveillance, both by patients looking at their own skin and by clinicians during checkups, play in catching these leakers really early, before they even get a chance to think about progressing? It really underscores the value of just being vigilant.
That's a great point. Vigilance and early detection really are key here. Okay, with that final thought, we'll wrap up this deep dive. For more free MSRA revision resources, visit freemsra.com. And for the full premium revision toolkit, head to pastthemsra.com.